everyone, it's your old pal, Jeff Horowitz with Dentists in the Know. Welcome to another episode of Humpday Happy Hour. Tonight's episode is brought to you by our friends at Practicioner. And by the way, just bought my fourth one. We're going to talk about that. And I'm really excited for my new Explorer Pro that's coming. Lots to talk about. A great guest tonight who is absolutely no stranger to digital technologies and to 3D imaging. We have Dr. Chris Stevens with us tonight. But as usual, I am joined. I thought I was only going to be joined by JB tonight, but indeed, Chad made it back from Oklahoma. He had some kind of an orientation for his daughter, Ava, who will be starting at the University of Oklahoma. So we're glad to have Chad. The whole gang is together, and we're excited. So welcome to Humpday Happy Hour and Dentists in the Know. We are your backstage pass for current trends, politics, and education in the dental world. We are live, and we are over a little glass of wine tonight, a little bit of white wine, a nice Alsatian blend. Kind of excited about that. Kind of excited to be with my best friends in the world, Dr. Chad Duplantis and Dr. Jennifer Bell. As you all know, we are all dentists, we are all educators, and we are all business owners. And our job is to bring all of you in the know. So let me bring up my friends. I think Chad's working on something. Maybe I'll just bring JB up and Chad will let himself in when he wants. How you doing, JB?
Good. How are you? I really like that new background that you have.
Isn't that kind of cool up there?
I
just have to figure out, I just need to work with the angles and stuff. I just got it up there. I'm going to probably move the desk back so I can be a little closer on me and on the background. But we're going to get this, but I'm kind of excited.
Or if any of you can get out your handy tools and some woodworking and build like a whole stand.
I just whittled it. I just whittled this. I believe you call it a chopa.
Yeah, there you go. Whittle yourself a little chopa.
I just whittled it out of wood.
Yeah, that's what we do.
Yeah. Very, very resourceful. So how's it going? How's your week?
Is it weird that it's Wednesday already? Is anyone else?
It is so weird. It blew my mind tonight.
I'm really designed for repetitive behavior, and now that it's Wednesday and I've only been working for 2 days, I'm totally just off my kilter. Totally.
Well, it's interesting. It screwed me up because really I'm designed for chaos. And so really this should fit right into my game.
Correct.
And yet it doesn't. It really messed me up tonight.
So obviously it doesn't work for anyone is what we've come to the synopsis here.
That is exactly what we've come up with.
Has your team done okay in the chaos?
Yeah. So things are good. We've probably gone through more change in this 1 year than any year I ever remember in my practice. And yet we're getting there where it's good and everybody feels good on the team. And that's just irreplaceable when you kind of get to that point, even when there's, a lot of change and a lot of interruption. And speaking of interruptions, hi, Chad.
I was just trying to figure out what the hell you did. That's all I was trying to do.
What do you mean?
I couldn't figure out how to get rid of the little banner at the bottom.
Oh, it's under banners.
No, it wasn't. But that's okay. It's neither here nor there. It's done.
Guys, we're dentists. We're not IT technicians.
Don't tell us you're not going to be on tonight, then show up and criticize what the other two hosts have done in your absence.
That's true.
Yeah. I made it.
Well, good. Well, tell us about Ada and Oklahoma.
Oklahoma is an interesting state. It's a very barren state with a very dull university that my daughter has chosen to go to. No, actually, it was a really nice day, a very jam-packed day, but honestly, I didn't know when we were going to get home. And we ended up making it, and I raced and I sat down here because I wasn't going to leave you guys stranded. I mean, Practicioner's a sponsor, and I'm not going to miss Practicioner. They've been very good to us. So
I love the level of commitment. I do.
Yeah, Besides, I forgot to tell you guys, I'm going to be gone in 2 weeks anyways.
Oh yeah. Well, we're kind of getting used to it, Chad.
Hey,
No, no,
also,
no.
I feel like Joan
could
Rivers,
you get my
when
parents'
Johnny
luggage?
Carson left.
My parents' luggage is stuck in DFW. If you could go
Is it
grab
from
it.
why?
Well, they were there for the week and they left today, although that was a bit of a disaster. Their flight got canceled. They rebooked to Raleigh instead of Greensboro, only to find out that their bags chose not to come. So they're still in Dallas.
I think that they'll probably arrive tomorrow and they'll just deliver them to the house.
Probably.
Yeah. Fun.
Yeah. Hopefully,
What airline?
they'll meet the Fockers and deliver
know.
someone else's luggage.
Maybe.
Was it American or Delta?
I really don't know. Out of Greensboro, I don't
There's
know.
a direct to Greensboro on Delta. I mean, on
Yeah,
American.
It
On
could be
American.
American then.
Yeah.
That would probably make.
I was gonna say. I mean, all the American hate. I was like, well, maybe we could get a little Delta hate.
We're
for
just going to
once,
dial
but
in on the hate.
no such luck. No such luck.
So, guys, I want to touch on something. We've used a little bit of time here, but this last week I was up at Align headquarters, Align Itero in Raleigh. We talked a little bit about it last week when I couldn't get my camera to come on. But it was really an interesting thing for me because we've all gone into integrating technology early in our careers. We all embraced it very early, but it's funny how different all of our entries were into, this digital world that we live in now. And so what I'm really excited about for our guest coming on is that he's kind of lived through all this. He's of my generation, if you know what I'm saying. So he's hip with it. He's down with it. He's cool. But my point
Is he getting
is
jiggy with it?
getting jiggy with it. So my point is that I went up to Align and I had been milling for a long time. I was, an early CEREC adapter and had been doing that for a long time. Got into some 3D printing, never really established myself in any of the design in any way and was trying to outsource that all the time and kind of put those pieces together between, capturing an intraoral scan, your 3D cone beam scan, then putting that into some design software and articulation and moving that to either 3D printing or milling or even sending it back to your lab. And so I'm really excited to have a conversation tonight. I know we don't have a lot of time to banter before you do the news, but I just find it so interesting how the three of us got into digital technology so differently, and yet we're all kind of landing in the same place via a different pathway. And so I'm just curious, like what have your struggles been in, navigating this 3D world that we live in now?
Well, I would say personally, it's if you have multiple pieces of technology, you have your scanner, you have your design software, or you have a CEREC, or maybe you have all of it like I do, where you're like, I have an Itero, I have a CEREC, I have a milling machine, I have a 3D printer, I have a CBCT, I have all of these pieces going. And every 15 minutes, there's an update of the software. So each company has a dedicated number of people. And you could argue that Align has, I feel like 400 dedicated people just to my software. I don't know, that's how frequent it feels like they're coming out with updates. And then you have updates coming on your CBCT. You have updates coming on your 3D printer, both materials and what you can print and design. And then if you have design software like an ExoCAD or you're designing in your CEREC scanner, you've got all these updates coming all the time. I can't keep up with what the new technologies, number one, its capability is, and the amount of time it takes for me to do each of those updates to learn all the new features, find ways to implement is pretty daunting. And they're almost outpacing the capability of the doctor to keep up. Like if you come on board with new technology, you understand everything that software can do at that particular time, and you'll know it really well. And then fast forward 2 years, I would argue that you will have lost 30%, 40%, 50%
No doubt.
functionality, because you won't have been able to keep up with the pace at which the updates have been coming through. And so for me personally, that's been a huge struggle, is to stay current in every piece of technology that I own, know all the ins and outs of all the new features. What are we calling it today? You know, was it called something yesterday and now it's called something different today? And then how all of them integrate together. And the last piece I'll say is, then on top of that, how much manpower, your outside hours of the clinical time you have to learn the software well and design and develop your own protocols and systems that you have, because no one's kind of giving you a cookbook and saying, this is how you're going to design all your occlusal splints, Jeff. Like, just press this little button and magically you'll have all the answers. Like, it's just never that easy. So that's, for me as a fairly digital doctor, I feel pretty overwhelmed with that on a daily basis.
I really appreciate you saying that, because you are the youngest of this group. Flash forward another decade, there's Chad. Flash forward another decade, there's me. So imagine, you know, for me, always feeling like I'm falling behind, that somewhere that I've never been in dentistry before. And yet I really feel that. And those 2 days in Raleigh were just so invigorating for me. I mean, it's like every time I do something, and, you know, I was an early CBCT adopter. And even with that, I was so on top of it. I mean, I don't think there's many that can read a scan, you know, in as much depth as far as being a general dentist. But yet every time we see how else we can be using our CBCTs and how we can be integrating that into our design and our implant planning and things like that, it just blows my mind. So what's your perspective on this, Chad?
I would have to agree with everything that JB says, but I think I'll sum it all up that I think the competition amongst the companies has created disjointedness amongst the technology. And I think that's the biggest frustration that we have. You know, you're on team A, B, or C, and there are certain things that you can and can't integrate with. It's not necessarily because it's a closed system, but it's just due to some proprietary software issues, I would say. And so it creates kind of a little bit of confusion, you know, when you're trying to integrate certain other pieces of technology. You gotta make sure that it's all going to play nice together, and that it's going to play well together, and that it's going to play efficiently and easily together. And unfortunately, that's not always the case.
Well, very, very well summarized, my friend. So I'm just glad we've got a guy like Dr. Chris Stevens on tonight, who's going to help us maybe chat about this some more, and maybe make us all feel better about integrating these technologies. And thank you to Prexion for sponsoring this episode, a great educational partner for us. Even before DINKs was a thing, Prexion has been right there with us, supporting us in CBCT technology. And so with that, I'm excited to get him on. So I think we need to let you do the news, JB.
Is it time?
I think it's beyond time, but I just miss seeing you two so much. I love chatting with you.
Well, first off, I want to make sure everyone has at least seen my updated version of the Marquette privileged license video that oddly kind of took a life of its own. We didn't really see that coming. In full disclosure, we've been doing the news for 4 years and have never seen quite the response that we got from that video. But hopefully we've cleared the air on a few items that were maybe being discussed pretty heavily, especially the fact that Marquette is in Wisconsin. We may now say that on every show just to make sure that the air has been cleared and the record has been set straight. In other news, this is kind of an interesting story because I think it starts to set some interesting discussion points around this jurisdiction of decision making that happens at the state board. So just for a little background information, some states have dental boards that operate fairly autonomously. They are filled with open positions from dentists or a dental hygienist or members within the dental industry or in the state. In other states, they are filled with politicians, legislators, members of public health, individuals, maybe or maybe not specific to dentistry. So each state board's composition can look very different. Well, this story came out of Alaska, and yes, in fact, that is the state. The story made headlines because this particular dentist became famous on Instagram or social channels for posting a video that went viral of him doing a sedation case, oral surgery on a hoverboard. And the way that the headline reads, you would think, well, that must be the big story, the fact that he was performing dental surgery on a sedated patient on a hoverboard, but that really wasn't the big piece of the story. In fact, when they started digging in to this patient or to this dentist's history a little bit deeper, they found, at least allegedly, in the stories that we've read, some fraud and misbilling tactics and a few other nefarious activities that may have been going on. The hoverboard and video just brought him to public spotlight, highlighted the patient that was sedated who hadn't consented to the video, who then moved forward with charges against the doctor, which opened up a tremendous amount of liability for the doctor and all the other things that they discovered. Okay, why is the story interesting other than the fact that the doctor was on a hoverboard? Because the state dental board decided to revoke the doctor's license and stated that his activities, there was a whole laundry list of things that they had found in the practice, were not at standard of care, and so they were going to remove his license. The state Supreme Court backed up that decision. So they stood behind the dental board and said, yes, in fact, you have the authority and autonomy to make that decision. Now, that may not be true in every state, but at least in Alaska, that was the final ruling. Now, this gentleman actually stands to serve prison time for many of his activities. So it's not just going as far as losing his license. He is actually going to be sentenced for many of the alleged crimes that he's been charged with. But I think it sets up an interesting discussion as we've been talking about licensure and state dental boards, that the Supreme Court of the state of Alaska did uphold the dental board's autonomy to make that decision about an individual.
Another interesting news story for this week comes out of the great state of Oklahoma. We have a dentist there that comes to the aid of a woman in his community. Now, this isn't the first time that I've known dentists or seen stories about dentists who ultimately come to the rescue of a local community member, not just a patient. I do think it's an inherent quality of most dentists that we want to take care of people. And if we see someone in duress, we're going to do everything we can to help them out. I think it's one of the necessary qualities of a really good dentist. Well, Dr. Keith Montgomery in Oklahoma City is no exception to that rule. You see, when he discovered a female laying outside unresponsive, he suspected an opioid overdose and happened to have naloxone in his pocket to be able to administer, thus waking the patient up and bringing her back to consciousness. Now, why was a dentist walking around with that particular reversal agent in his pocket? Well, you see, Dr. Montgomery had experienced the loss from opioid overdose himself. He lost his daughter after being 4 years sober to one night of taking one pill that caused an opioid overdose. And he didn't want another individual to be victim to that particular scenario. So now he walks around with that reversal to help anyone else out in distress and to hopefully save their life while in that particular scenario. And it's his message to others that we should all be proactive in helping others avoid an opioid overdose, because you never know when it might just have been that one occurrence of an accidental exposure to a medication. You thought it was something and it ended up being something else that ends up taking a precious life. And that's the news.
JB, where was this that story came from?
Oklahoma City. He practices in Oklahoma City, so I think it was probably somewhere in that vicinity. Dr. Keith Montgomery.
I take everything back that I said about Oklahoma at the beginning of this presentation.
For real? You better.
Yeah. No,
You know,
that's
experiences, life things will change you. And the fact that he had it on his person, just, walking around in his community meant that, that just tells you how deep the cut goes for never wanting to experience that again, or if he can be any small part in preventing that for somebody else. So I thought that was a pretty powerful story.
that definitely was great story. Great.
Hopefully I got all the facts correct.
Yes,
I'm
and
sure
everything
everyone will
was
fact check me
factually
later.
correct.
Are you sure
Alright.
it wasn't in Oklahoma City, Michigan?
Yeah.
If this was actually in Oklahoma City, Michigan.
Okay, I'm
So
just making
our
sure
hearts
it's
go out.
not Wisconsin, not Oklahoma
Yeah.
City,
No,
Wisconsin.
Nothing happens in Wisconsin that I'm actually aware of. Nothing.
Okay. I just
Yeah.
want to make
Is
sure.
that a state?
Oh,
It
you
is.
just pissed
Yeah.
off everybody. There you go.
I know.
All right,
Yeah.
let's bring our guest on.
Let's do
Jeff,
it.
You want to do the honors of introducing him?
So I would be absolutely happy to.
Except I'm not going to join now because I live in a state that doesn't exist.
I knew you were going to bring that up.
There you go.
It
Yeah,
does.
you
I
know,
went to some pansy
Correct.
dental school that doesn't require boards.
it's always the blonde in the room. I'm telling you.
Yeah.
They ruin everything.
She
They
pisses
really
off
do.
so many people. I'm sorry, Dr. Stevens. Bear with us for a
And as
moment.
long as there's a Dr. Chris Stevens and a Dr. Dan Taché, Wisconsin is on the map for me.
All right. Thank you.
Absolutely. Well, everyone, this is Dr. Chris Stevens, who is also a great friend of ours, a great friend of Prexion, and he has a practice in Sun Prairie, Wisconsin, not Michigan, JB, that's Wisconsin.
Got it.
And
On it.
same place that Marquette happens to be, just in case we want to make a note of that. Anyway, Dr. Stevens has been lecturing and implementing digital technologies in his practice for a long time. He's of my generation, so I saw a little 1991. I'll just have everybody know that was my year of graduation, so you might have a year on me. What's that?
I'm 1981.
Oh my gosh, really?
Yeah, I'm way older than you are.
Don't act
And-
so shocked
and
next
is
time,
it-
Jeff. Just roll with it.
JP's like my daughter.
What? You still put sentences together so well.
With that fix-a-dent. That helps.
We're burying
Can't
this
even hear it
show.
moving.
I know.
Carry on,
Anyway.
Jeff. Carry on.
Let's carry on. Anyway, Chris was an early implementer for CBCT technology, very knowledgeable about it, and has spoken, as I said, on many digital technologies and implementing digital technologies, integration in dental practice. So, Chris, what a pleasure it is to have you on. And tell us how your week has been, because we don't ever do that. We always ask each other how our week has been. We never ask our guest how their week has been.
Wonderful. Except yesterday I played 2 holes and got rained on.
Now that'll piss you off.
Yes. Yes.
That'll piss you off. Yeah.
Chad, he has different kinds of problems on the pre-show. I don't know if you heard this. He was complaining about his caddy. Okay.
Oh.
Difference about his personal caddy. Whole different set of problems than we have, Chad Duplantis.
Yeah, that's true.
Chris, tell us a little bit about your background, just for everybody out there, just so they can get to know you a little bit better, and kind of what's driven you in your private practice, and what's driving you now.
As you said, I started a while ago, and I became very interested in bioelectric instrumentation. I was a beta tester for Invisalign, and CBCT just it came after Invisalign, and really the reason it came after Invisalign for me was because I thought I wasn't placing implants, and I thought it was kind of just a deal for oral surgeons and GPs placing implants. But the hygienist came to me one day and said, "Do you realize your patients don't want to leave the practice when you're referring out for implants and how much production you're losing. So what I did with CBCT is I used a mobile truck. I pre-selected my patients that I said, hey, I want to do an implant on this patient, but I probably should know where I'm going before I start. So I had a truck show up, got me some images. It was very discouraging. It was discouraging to me because what I found on those 3D images that I didn't see on the 2D images that made me refer them to the truck was incredible. And I felt horrible about it. How much am I missing on my individuals? So that's what really drove me to say, I need to buy one. I was concerned about cost like so many people, but when I talk to my patients, I don't talk cost, I talk value. And value to me is benefit minus cost. If the benefit to the individual is greater than the cost, great, they have value. And that's what I had to decide is what value is there to me in my practice for CBCT. And once I realized how much I was missing by these select group of patients, I said, well, there's no question there's value. So we got one. We used it on every patient, not just new patients. All the recall patients got them. If they needed a full series, we called it a full series. It really became disappointing that I didn't invest earlier. Yes, I early adopted on a lot of things, but because I wasn't placing at the time, I thought, nah. So of course, then you have to decide, what am I buying, right? With so many competitors, as you were describing out there, what do I purchase? And I ran into Prexion, and I was impressed. I was impressed with their software manipulation. I don't know anything else about the technology. I mean, it's way beyond me. But it was interesting. I had a tough case that I didn't think I was qualified to place an implant for. And so I sent the images to an oral surgeon. He calls me up. He doesn't want to discuss the case. He wants to discuss the images. He says, where'd you get these images? I said, why? He says, they're incredible. They're so clear. He says, I want to know the machine because it's way better than what we have. And so between the images, the image quality, I hadn't looked at thousands of images to compare image quality. I looked at different vendors. I like Prexion, but I like their software. And so that's really why I bought it a lot of years ago. But
yeah, that's what I was going to ask, Chris. I think you alluded to it, but what year was this that you had your first Prexion?
15-ish.
Okay.
14-ish, something like that. Yeah.
I've asked multiple maxillofacial radiologists, and I've always heard that Prexion just has an outstanding image quality. And of course, there's a number of reasons that we all gravitate towards it. And sometimes when you have something that a lot of others consider one of the best, you don't really realize it until you compare it to something else. But I'll get images from people and, definitely notice a very different quality in what we're taking versus what others are taking. And Chris, are you familiar with Dental Ray at all?
I am not.
Okay, well, Dental Ray, they do medical overreads of images, and it's done by a lot of neuroradiologists that are MDs, not dentists, obviously. And they're always talking about how good the image quality is of the dental CBCTs in general, and especially Prexion. So I think we've got a great system, and there's a number of reasons that it's great. But I love your story and how you kind of got into it, and I think that's just really just an outstanding story to be able to share. What would you say that the biggest thing that you noticed that changed in your practice once you brought 3D imaging in? I mean, what maybe was it implants? Was it endo? Was it just the overall holistic approach, whole body approach? What was it that it brought to you?
I hope I never see gutta percha again.
I agree. Amen. Yeah.
This does feel like it's become an anti-endo show.
Yeah.
It really
Sorry,
does.
Walsh.
Yeah, sorry.
It's
But-
not
Love you, Don.
anti-endo. We just brought Walsh in for that purpose.
Yeah, we love
Yeah.
endodontists,
Yeah.
but we mostly don't.
Right. Love endodontists, not necessarily endodontics.
Yeah.
Yeah.
Right.
Yeah.
I refer out centrals. Right.
Same.
So, yeah.
We're endodontites.
No, I really can't say whether there was a particular discipline that jumped out at me. Obviously, I started doing more implants because I was confident in what I could do, where I was going. I love Henry Kissinger saying, if you don't know where you're going, any road will get you there. And so I didn't want to be that person. There were really three things that helped me. First of all, diagnosis and patient engagement. And by that, I mean just the ability to enhance my diagnosis, but also engage the individual. So for me, I always thought patient education was a key to doing care. And Paul Homley taught me that really is wrong, that readiness is the key to doing care, because how many smokers are unaware that smoking is bad? They all know it. They do something about smoking when they're ready. Maybe they have an illness like lung cancer or something. Patients do things when they're ready. So what happens with the CBCT is they can see the problem so much better, and it creates what I consider to be a readiness, driving them to do the care. They own that problem, and I want to create concern in the presence of concern. I want them to do something if there's a concern. So I need to create that concern, and to do that, I need to engage them to own the problem. I had a patient that worked for Dentistry, Tulsa. She had a 2D lesion on number 30 for a long time, would not do anything. You know why? Doesn't
Couldn't
hurt.
see it. Yeah. Yeah.
Okay. I showed her 3D, and that lesion, how close it was to the inferior alveolar nerve, and immediately she went and did something. It just created readiness. And that's what I find to be such a big part of when you ask, well, what part of your practice? Well, readiness is the part of the practice that benefited the most. Certainly treatment planning, right? I mean, and if we have time, I'd like to talk about a third item is prognosis. That dentistry doesn't talk about prognosis. Why? Because we fix stuff, right? And patients expect that it's fixed, done. Not in medicine, right? And so CBCT also allows us to talk about prognosis, what truly exists on patient presentation. In my courses, people ask me about success, and I say, you know why I'm successful? I bring patient expectation down to my ability. And really, that's sometimes what we always have to do is they come in expecting everything to go well. It's a dental office. It should, right? Well, not necessarily. And so the engagement, the treatment planning, the prognosis, all three of those things have made a significant impact, not only in what I'm treating, how I'm treating, but how I feel about what I've done after treatment.
There's two cases that come to mind that I can relate to both of the points. Well, you made several points, but 2 points that you just made. The 2D image versus the 3D image, and getting a patient to act upon it. A well-educated, in our practice, lawyer that would not act upon a 2D lesion. There's no pain. You show him in 3D, it's like, oh my God, why haven't you told me to do anything about it? And then, the second case, you talk about prognosis. I mean, you look at something that's, let's say, an endodontic lesion again, that's been treated twice. And you've got this lesion and you're like, this tooth is hopeless. Yeah, we can go do it again. We may get it to resolve, but you know what? It's probably going to come back. Now, the endodontist may argue with me, but how many times do you want to keep throwing money at an endodontic treatment when you can go get a nice titanium rod placed in there and it's probably never going to give you another issue?
Yes.
You know, and so I love what you said about prognosis and creating readiness. That's just such a fantastic quote. So
You
I
know,
couldn't agree
I
with you
would
more.
say in that same line, and I don't know, Chris, if this is part of your discussion, but many of us oversell in order to have the opportunity to treat, right? We say, yeah, this will go well, it'll be fine, you know, no problem. And I think your discussion of prognosis is so important. What you can see on that three-dimensional image, when you have we'll just use a very crude term, like bombed out area of highly infected bone. And the
That's
idea
not
is that you're going to
crude.
be able to go in and denude the bone well enough that titanium will be successful in that particular scenario. How many times have you seen it fail? And I know I have, because ultimately the bacterial compromise of the area, the bone compromise, had a lower prognosis than a tooth that had no bacterial inflammatory issues. So talk to us a little bit about how you have that conversation with patients about using the terms prognosis. Is it percentage based? Is it length of years? And how you sort of manage their expectations?
You know, maybe I could tell you a story. I had a young lady come in with her mother, and the orthodontist referred her in because she unfortunately had cleft lip, cleft palate. She's 17. What a horrible thing for a young lady. And the orthodontist wanted to know if the space was appropriate in number 7 for an implant. She had a graft placed by an oral surgeon. He's getting ready to do the implant, but she's thinking restoratively. How wonderful is that?
That's nice.
So we get talking about it. And she asked a very difficult question. Do you place implants? And I'm thinking, oh boy, here we go. The orthodontist refers her in on behalf of an oral surgeon, and I'm going to steal this patient, right? Is what I'm thinking. Oh, this is not going to go well. And I said, well, we do. Well, can you place the implant? And my answer most often is, I don't know. But let's do this. Let's get an image. Let's see what's there, right? And of course, we'll throw the image in if I'm trying to sell a case, right? Like you do. If it's a shopper, not so much. But we take this image. There's no bone graft there anymore. And next to it, the number 8, half that bone is gone. Now, where do we go with this? 10 is congenitally missing as well. So I happen to have another oral surgeon friend who spent JB, Illinois is just below Wisconsin. And
I feel like you need a pull down map with like a stick and you just start pointing stuff out.
And he spent 10 years as a cleft surgeon at Rush Memorial in Chicago. And I consulted with him. He said, there's no way we're doing implants here. I said, well, okay, so the patient comes in wanting an implant. I'm going to add to her smile. I'm going to tell her that I got to pull a central out because there's not enough bone. And then what's one central going to do, right? We're going to have an intermediate abut. So let's do this. Let's pull 2 centrals out, right, on this pretty young girl. Well, he says, no, do a bridge. He says fixed bridges will last longer on clefts than you would typically think. But we had the discussion. Look what you've presented with in bone level on this tooth. I know you want this bridge I'm going to do to last forever. You're 17. It's not going to. And so they expect to have to do this over. They expect that possibly sometime they may lose 2 centrals. But guess whose fault it is not? It is not me. Yes, it is not my bridge that failed. It's their presentation. And so being able to have that conversation, another saying I have is predict the potential rather than excuse the result. And
Good
really,
God, you're
that's
just full of them.
I know.
Yeah.
You got to type that one in too.
Yeah.
You're like Yoda.
Jeff, you probably know I spend a lot of time in the shower thinking. Okay, but that's another.
I'm not going there. Not that kind of show, Chris.
We need one more hour on YouTube before we can go there.
Those things might happen in Wisconsin,
Yeah. Not on my channel,
which is
damn
right
it.
above Illinois and right next to Michigan.
Yeah. So they say.
But how comfortable it is knowing that the parents understand that they're spending a lot of money on this care to buy some time for this young lady that they call their daughter. So for me, I just felt a need to bring prognosis into the equation like medicine does. And dentistry seems to, there's a joke about what's the difference between God and a dentist. God doesn't think he's a dentist. Sometimes we do think like we are God, and stuff just doesn't go the way we want or last the way we want. But
I actually love where this conversation is going, because I also know that you are also a scholar of temporomandibular joint disorders, and I know that this is a passion of yours. And for me, that's been one of the biggest components in managing risk, has been looking at the foundation and will this bite be long-term stable? Because if you don't have a healthy foundation, you're never going to have a stable bite. And so tell me your perspectives, because for me, I started taking larger fields of view very early in order to gain more comprehensive diagnosis and risk management protocols. So I'm curious what your perspective is on all of that with regard to being able to find things going on with the foundation that could affect your outcome for any kind of a case.
Traditionally in the TMJ world, and I'm probably in fourth place on this screen in the TMJ world, we've talked about phase 1 and phase 2. Phase 1 being diagnosis and treatment, phase 2 being stabilization. I never understood that. For me, there was 4 stages. Diagnosis on its own, because that's a complex entity. Then therapy. How are we going to alleviate symptoms? The third stage is stabilization. What do we do? Do we do orthodontic stabilization? Do we do reconstructive, crown and bridge reconstruction stabilization? What are we doing? But stabilization is only done in our office to remove the appliance daytime. Maintenance is the 4th stage. Again, that maintenance talks to prognosis. You mean I'm not done after I spent all this money feeling better and stabilizing? No, you need to maintain it. And based on their presentation, what I saw on these images, because I had in the late 80s, I had linear tomography.
I did too. Did you have an axiotome?
I
had that dinosaur. It weighed about 17,000 pounds.
Yes. And I love tomography, but CBCT, just to be able to move those condyles around and look and what I found sometimes was incredible. So that spoke to prognosis. But see, Jeff, when you enter into the TMJ world, you're stepping a little bit away from the dental world and into the medical world, where you do talk about prognosis. So for me, that maintenance phase helped them understand that we're not done. This is like diabetes. We don't just fix this. We manage it. And how long do we manage it? Well, until you die. Now, some people manage it better than others. That's great.
Die or move away.
Yes.
I
Or I
do
move
love
away.
geographic success.
Yeah. Geographic mortality is a real thing. And yeah.
You know, one other area that we haven't really talked about, though, yet, if I can, is treatment planning, which comes before prognosis, after diagnosis, you know. And what this instrument did for me, you know, probably a classic case that comes to mind for me is, and his brother threw him the ball, and he was facing away, turned around just in time to receive the ball in his face, and it knocked out number 9. So we get to see him, and I take a 2D image. You know what? I might be able to graph this. Let's take a 3D. The coronal view looked great. The sagittal view looked great. I pull up the axial view. He's got 3 fractures in the socket. I'm going, if I had 2D, there's no way I would have seen this. If I wouldn't have looked at the axial view, I wouldn't have seen it. I mean, just having that ability to manipulate these images in any plane that you want. So of course we weren't going to place an implant right away. We had to graph that, allow healing, re-image, make sure that it's matured enough to receive an implant. All of these things really make a difference for treatment planning as well. So there are so many more cases that I could talk about, but when you can see something is that significant on one of the views that you have no opportunity to see in plain radiography, I mean, what are you doing not having a CBCT?
Chris, is that part of your new patient intake? Help our viewers, if they're thinking about bringing on CBCT into their practice, what's your current protocol? Every new patient gets one. Is there a recurring image frequency that you do? And then lastly, how do you massage the topic with our anti-radiographic individuals that come to the practice as well?
Well, before I had CBCT, you know, you'd take a full series. Okay. Let's say that you take a full series of intraorals. JB, how many images is that in your office? Full series.
What is that, 17, 18?
Not in mine. It was usually about 25 because we had a bunch of retakes, right?
Yeah. Okay. I think that's fair. That's fair.
Right. Yeah. Right. And the amount of radiation.
And in the current environment, that seems to be more and more. But
yeah.
40. A full mouth is now 40.
75.
The amount of radiation out of a practitioner is less than a full series of x-rays, even if you took 18, right? So I haven't had patients worried about exposure. They think you are cool. Look at the instruments you have in your office. You're way ahead, aren't you? I mean, so patients, I didn't have them being concerned about exposure. All new patients got one, 4 bite wings and a CBCT. Jeff, do you take bite wings or do you use your CBCT?
So that's an interesting question. Typically, we will take bite wings, but the first thing that is taken on every new patient and any patient that does not have a scan within 3 years is a full field of view CBCT that we break down. And then once I look at that, then we decide if any adjunctive radiographs are necessary. Okay. And many times they are not.
Right. I don't rely on 2D to substantiate something I saw.
That's 3D, right. That's it. And yeah, exactly.
So we take the 4 bite wings. I still, I have to admit, I still struggle a little bit with caries detection on a CBCT.
Sure.
Right? Incipient caries, early caries.
But don't you agree that we have so many other great tools now for detecting caries that really why we are relying on a two-dimensional image that doesn't tell us whether the lesion is buccal or lingual, where it is, if it's burnout? I mean, you know as well as I do, you put the same set of bite wings in front of 50 dentists and you're going to have 30 different diagnoses.
Yeah. JB, did you ever develop film?
Yeah, I did. Do you want to know about my first experience?
Why didn't you ask me that?
Series?
Because I know the answer for you.
Yeah, so I was an intern. I was wanting to go to dental school. My dentist took a chance on me. The first full mouth series that I developed for him, I glued them all together in the I thought it was a race, so I just kept feeding it into the machine very quickly, and then they all came out in one big.
They came out mounted.
Yeah,
they were all pre-mounted for you. Yes.
Yeah, they were. It was a very rigid mount, and no one was really super pumped about that.
Well, what I noticed is that the image quality has declined. I felt we needed more radiation to take bite wings when I graduated. And then we got into fast film. Okay, now the image quality went down a little bit. Then you also had developer fixer issues, blah, blah. So digital was great, but I found my old x-rays had better contrast than the digital x-rays. So Jeff, to your point, are digital x-rays the best thing we have for decay detection? And I'm not so sure, you know?
Well, the other thing too, this is really interesting. So, you know, the average focal spot for an intraoral x-ray head is like 0.4, 0.5 millimeters. And now you've got Prexion CBCT scanners that have a focal spot that is actually smaller than those on most intraoral heads serving most dental practices at this point. And some go as high as 0.7.
And you're right, where is this lesion? Is it buccal? Is it lingual? Occlusal decay. How often, you know, I don't do sealants because I found my patients were coming back with undetected decay under sealants, right? And fluoride's created enamel to be so hard that it doesn't collapse like it used to when I graduated from Marquette.
In Wisconsin.
And so just having the ability to see occlusal decay by cutting that slice is very helpful. So I still take bite wings, but all patients get CBCT, and recall patients that are due for a full series, we don't take pans, although Prexion has a terrific pan module. I mean, the Panorex is, if you choose to take a Panorex, the Panorex on a Prexion is unbelievable. It is like nothing I've seen. But we don't take pans. We just take 3D. And I get questions about, what about insurance billing? We just bill it as a full series.
So I have a firm stance on that too. Why would you ever take a panoramic when you have an instrument that will give you 3D rendering and get so much more information? And you can bill that to insurance legally. Just for everyone out there, I have made most of the money that has recouped my cost in CBCT scanning, which my first machine was $195,000. Before Prexion was even on the radar, I bought an iCat that was $195,000 and built a $20,000 fortress room to house it in because of all the regulations in South Carolina. And still, like, my practice boomed. The ROI was beyond anything I've ever bought in my practice because, one, every new patient got one. You can render a panoramic image from the CBCT,
Yes.
fill out a panoramic. Patient is not out of pocket any more than they would have been in any other condition. And yet I have so much more information. So that more than paid for my machine that was over $200,000. Just the panoramics I was charging out. Now add all of the new TMJ treatment and implant treatment and airway treatment and all the things that I could now diagnose because I captured a 3-dimensional image versus a 2-dimensional image where I never would have seen any of that pathology.
You know, I guess I never. I'm not a smart man, and I never bought.
Oh no, you're a brilliant man, actually.
I didn't think about ROI. I thought about patient benefit, and for me, the ROI came naturally because my diagnostic capability was so much better. So it was a natural progression to have a return, not because I was trying to make money on CBCT, simply because we're trying to do better care for these individuals that trust us to treat them. I think that's the big responsibility. And I know for myself, I really am disappointed I didn't buy one earlier. That's, you know, we all have regrets. I like Condoleezza Rice's statement about she doesn't believe in regrets because she did what she thought was best with the information she had at the time. Great. But yet I still have a regret not buying sooner because I think I could have helped people better if I would have had it.
Sounds like
Love
a
that.
closer, guys.
Oh, are we at 9:30?
We are. I tell you,
It was just such a good statement. Also, that it's just a really way to put a great capstone.
This is my jam. I could have talked about this all night long. I don't know about you all, but you know, people on YouTube probably don't want to hear us all night long. I mean, we could talk all night long. I liked him a lot better when I didn't see the shirt because the Packers have beat the Cowboys 5 times in the playoffs. The Cowboys have only won 4 times. They beat us this past year, but then again, I'll get over that.
Cowboys have really sucked.
Anyhow, Dr. Stevens, thank you so much for joining us tonight. I mean, what a great conversation. I love your passion. I tell you what, you can add your name to the list of famous quoters with all the things that you said.
Yeah,
you had
absolutely.
some really great ones. I want to throw out that my favorite was it just created readiness. I think that's fantastic. And the other one was the one about the prognosis. I think that was fantastic too. But, you know, we were talking as we were closing about certain things, and maybe I picked this up indirectly, but one of the things related to profitability, because when I'm presenting on CBCT, a lot of young dentists are looking for a profit center in their practice. And I always say that diagnostic capability is not your profit center in your practice, but it's always going to be your breadwinner, because if you use it appropriately, you will be a better clinician, you will be a better diagnostician, you will treat a lot more cases, and in the end, it will be extremely profitable. But don't be chasing the dollars from the image.
Yes.
Chase the treatment that comes out of the image legitimately.
Yes.
And I think that you will be extremely successful. It just makes us better dentists. And as we close, I also want to present today. I got home and I found this in the mailbox, and it was dental economics article. And one of the things that I noticed is it says, highlight the oral systemic connection to elevate your practice. And that's really what this is all about. You know, we've got so many opportunities with CBCT. We've got so many opportunities just make us just all around better clinicians. And as I always say, physicians of the oral cavity rather than just tooth mechanics. So
now you want to be in the quote business?
no.
Yeah. Now all of a sudden you're
Wow.
I'm
There's always a
supposed
one-upper in the group.
Hey, look,
There's always a one-upper.
look. Here's the deal. You open, she does the news, I close. So
Exactly.
Shut up and let me have my moment.
You told
She
me.
went viral.
Yeah.
Will your clothes go
Hey.
viral?
Yeah. She always goes viral. I never go viral, but hey.
Just tell him you can't wait to visit him in Virginia.
Yeah. Well, and when we're there, I'd like to stop by your alma mater. If that's okay.
You know, many years ago, we visited the Dallas area, and my cousin lived in the neighborhood with Troy Aikman, and I have 3 sons. And every day we were there, we had to drive by Troy's house just to see if he was out mowing the lawn, and he never was. That was disappointing.
I don't mow the lawn either, and he's got a hell of a lot more money than I do. So there ain't no way Troy Aikman is mowing the lawn.
That's what I tried to convince him, but we're going to check it out either way.
Your family member lived in Willow Bend. I know it very well. I lived right there, grew up right there. It's a great. I wasn't in Troy's neighborhood, but I was down the street in the poor section. So
mowing his yard.
I was the guy out there mowing his yard.
You actually saw Chad.
That was actually mowing the Aikman's yard.
That was actually Chad.
Yeah. That's my claim to fame. I mowed Troy Aikman's yard. Yeah.
Everybody's got one.
So.
All right.
Anyhow, everybody, have a great night. Thank you, Dr. Stevens. And thank you again, Prexion, for just creating such a great quality product for us to be better at our diagnostic capabilities. So everybody have a wonderful evening. Thank you.
Thank you. It was great to have you.
Great seeing you, Chris.
Good night.
Good night.
And that wraps up another podcast for Dentists in the Know. On behalf of Dr. Jennifer Bell, Dr. Chad Duplantis, and myself, remember that we've got a great profession, so let's make it a great day, Dinks.